Hi, everybody. For everyone listening in, this is the first podcast in the Pain Management Service Line series. We're very lucky to have with us today Dr. Mahipal Chaudhri. He's a general psychiatrist practicing in Rochester, New York. Dr. Mahipal Chaudhri's background is that he's done his psychiatry residency in Kansas City, with subsequent fellowship at Massachusetts General Hospital. His areas of interest include psychosomatic medicine, which include interactions with multiple different specialties, as well as forensic psychiatry and addiction medicine. So welcome, Dr. Chaudhri. Thank you for being with us today.
Oh, thank you, Dushyant. It's my pleasure.
Great. So, Dr. Chaudhri, we don't have a lot of time, unfortunately, so we'll kind of get right to it. Now, the topic of and the theme of today's talk is essentially how to deal with patients, particularly focused towards the future interventional radiologists and even the current interventional radiologists who see patients in the clinic setting, who see patients before procedures, as well as immediately after procedures, oftentimes not knowing them directly, and the procedure, and patients often seeing them for the first time just before a procedure. So we're really going to focus on identifying anxiety and issues that come up with patients and how to address those issues. So, Dr. Chaudhri, the first topic that we'll kind of glean over is just that. We have a lot of patients who have acute as well as chronic conditions. Acute conditions such as a trauma, oftentimes such as like a splenic laceration or an injury, doesn't really give time to explain a lot of risks and benefits. We just kind of emergently go in. Focusing more on the chronic conditions, we have patients who have cancer, like hepatocellular cancer, renal cell cancer, also other chronic conditions such as diabetes or renal failure, for which interventions such as chest ports or may be required, or drains and tubes to be placed. Now, given the sort of variety of patients that we deal with, one common theme is anxiety. Dr. Chaudhri, could you speak to how you identify anxiety in patients and some tactics to deal with that?
Sure, Dushyant. First of all, let me thank you for this effort. I, being a psychosomatic doctor, I have always been quite interested in finding a way between psychiatry and other disciplines. So, as far as I'm concerned, I'm very excited that you guys are involved in this kind of work. And Society of Interventional Radiology is I'm proud of them that they have involved themselves in this interface of psychiatry and medicine. And so let's get down to the anxiety part. Now, anxiety is a very common condition. The procedures that you guys do are also very common. So one part of the anxiety is part of a natural disposition. Sometimes we hear about it in terms of fight and flight response. So whenever there is any talk of procedure which is going to be, for the doctor, it may not be too intrusive, but for the patient, just the thought of it can be fairly anxiety-provoking. So some of the tricks that we can utilize to alleviate anxiety in the patient would be just the common ones that a good doctor does anyhow, but I'll outline those. Any friendly professional demeanor would allay some of the anxieties with the patient. And if you are meeting with the patient as a consultant, then definitely we need to spare a little extra time with the patient so that we can answer any questions and also create an environment of care and concern. So when we approach the patient, we should have general friendly demeanor, little social smile, and we should have in my judgment, the white coat should be worn, and we should shake hands, make eye contact, and acknowledge any family member who may be with the patient. And it should also be encouraged that that if there isn't any family member on the first day of the consultation, that patient should bring in somebody who he or she feels is supportive. It is always a good idea to do so. The second thing would be the discussion should be somewhat concrete and allowing the patient to ask questions. So general outline of what the procedure is going to be, without any emphasis on the severity of the outcome or the pain or anything like that, would be a good idea to get started early on. But of course, we will explain all that at some point in the contact. But early on, to establish rapport, one needs to be somewhat concrete in giving information to the patient and seek any answers or any questions that the patient may have. Now, as the interaction goes on, one would be outlining the risk-benefit ratio. The approach should be more from the positive end of the procedure, such as what are the benefits and how the procedure can help the patient, how one's experience has helped the patient. So from positive angle and towards the maybe middle of the interview or contact, one can start to talk about possible adverse effects or side effects from the procedure, and give enough time to the patient to ask any questions about that. And in the end, one can still outline the positive aspects of the procedure and reassure the patient that patient can seek any more reassuring answers that the patient may need. So that would be the early contact. And also one can do some kind of screening assessment during the first consultation, and looking for things like a person's demeanor can give you some information as to how the internal state of the patient is. Say, for example, if somebody is coming across somewhat stoic and somewhat hypervigilant, that would mean that the patient is feeling somewhat afraid in terms of the emotions underneath. If a patient looks nervous from the facial expressions, that would be another sign to look for. If a person has, say, dry mouth, there may be some indication in the speech that possibly there is anxiety the person is experiencing. And patients who tend to be very anxious, they come across more clingy, or they need a lot of assurance, and they would ask those questions where where they feel that the doctor is going to do things in the best interest of them, and also they want to make some special effort to seek assurance from the patient, from the doctor, and they may be asking those questions repeatedly, whether doctor, I will be all right or not, those kind of things. And if the patient has fear underneath, such patients generally stay somewhat distant, and they would ask fewer questions, and they tend to be more concrete, and don't go into the depth of the situation, but just ask simple things like, what's my chance of having any adverse effect, and what's the chance of my getting the benefit? So one can pick up some of these patients for whom we may need some kind of special consultation with a psychologist or psychiatry at some point. Now, the emotional symptoms are very common in the general population. Because of that, I would suspect that any specialty would experience about 30-40% people who have some kind of emotional either reaction or emotional condition. Say, for example, 25% population has a clinically diagnosed depression, and depression and anxiety, they coexist. So there will be a fair number of patients with some type of emotional issue, whether it is acute or it is in the background, or something that may come up after the procedure and in the subsequent follow-up. Now, the anxiety, I mentioned some of the anxiety symptoms that one can pick up from the behavioral aspect. But in general, the whole anxiety condition would have 3 or 4 discrete areas which can be identified so in terms of neuroanatomy, and they are in the area of autonomic nervous system, which is attached to the limbic system. So limbic system has the, you can say, highest level of emotional area in which there are discrete areas for anxiety, fear, and depression. So that area of the brain / autonomic nervous system would lead to symptoms such as difficulty breathing, palpitation, knot in the stomach. There may be tremors or increased perspiration, or patient may say that I cannot breathe properly. I feel as if somebody is sitting on my chest. Then you can have symptoms from the hypothalamic area, which are person may not feel hungry, maybe feeling stressed out, cannot sleep. There may be symptoms in terms of feeling weak, and maybe symptoms in terms of losing interest in day-to-day life. And then there would be symptoms pertaining to the prefrontal cortex. As the level of anxiety increases to a stress level, initial part of the anxiety is normal and is motivational in nature. So we do need anxiety. But at some point, when the anxiety is excessive, it starts to cause symptoms such as sense of overwhelm, over anxiety state, or panic state, or stress state. In that state, the person's ability to attend or to stay focused gets compromised, and the ability to think logically also gets compromised. So a person who is overly anxious would show those symptoms, and the doctor may have to repeat information over and over again. So in a situation like that, the best thing is to write out the answers for the question for the patient, or have the patient rely on the social support who the person who the patient thinks is the best social support, and that person can repeat to the patient later on if there are any questions the patient is worried about. Now, in terms of symptoms of depression, the depression is one of the conditions which involves the whole body, and what is proven in our field is that if depression is present, the recovery from any procedure, whether it's invasive or it is relatively minor procedure that we doctors think is minor, but for the patient may be a major thing, because for the patient they are going by their emotional state, and in depression the thinking of the patient tends to be negativistic. They cannot see positive in any situation. Their ability to focus and and to retain information is off. Their ability to enjoy things that they previously used to enjoy is compromised. They do not have enough motivation to go through the process, especially, when you guys are dealing with cancer patients or chronic patients, in terms of chronic medically ill patients, you would encounter quite a few people with depression. Say, for example, people who have chronic pain, after 6 months, about 80% of them would have depression. People with cancer would have depression after 6 months or so. Hence, these patients, we can put them in a special category because depression would be present there, and the conditions are such that a lot of patients or the family members or even doctors would say that, oh, if somebody has cancer or chronic pain, they're supposed to be depressed. Well, that may be true in terms of that we human beings do have emotional reactions to our life situations. But nevertheless, irrespective of whether it is understandable or not, there is a biochemical change in the brain. It would interfere with the care of the patient and even recovery from the treatments that we are providing. So depression should be looked at as a very important piece, whether it is understandable or not. It needs to be treated. Now, when we look at cancer patients, they are going through a few additional issues. One is that depression would be expected if somebody is dealing with some kind of pain in cancer or just cancer itself is very taxing on the body. So 6 months later, they would be in a state of depression, clinical depression. So cancer cells themselves secrete toxins which are known to cause biochemical changes in the brain, and hence that type of depression would be there. And then when we give radiation or chemotherapy, the medications or the treatment themselves would cause stress on the body, and the adrenal glands would be overactive and eventually get fatigued. So that kind of stress-induced depression would be there. Then the patients would have their own emotional reaction to the situation they're in. And people who are undergoing cancer treatment generally go through this phenomena, which is quite consistent among the human beings, called grieving process. And the grieving process could be anything. Say, for example, it could be grieving the possibility of having to go through chemotherapy and expecting that for a year or two one would be in a very distressing situation or very discouraging situation. So that is a major change in the patient's life, and hence is quite traumatic, and hence the grieving process would be there. If the prognosis is limited, then of course that patient would look at the overall situation as in terms of death and dying type emotional reaction, and hence that patient would be going through certain well-known emotional phases, and because these bereavement or grief-related stages are pretty predictable, there has been a lot of research done, and the way the research says is that we human beings would first be in a state of shock or disbelief that we have a condition which is lifelong or which has a very poor outcome or which can be painful. So we are, because we don't expect those kind of things for ourselves, and hence it becomes a sudden shock or disbelief that one is going through it in reality. Second, phase tends to be anger. In anger, one is upset that it's all unfair for me, for my life to go through this type of pain or this type of procedure or something uncomfortable and possibly very poor prognosis. And then comes the stage of depression. Then comes the stage of bargaining. Now, bargaining means that, okay, I'm going to live for X number of months or years. Let me have the best of it. So the focus changes towards what's the best that can be done in a situation that is quite disturbing. And then the fourth is the stage of depression, which means that one starts to now look at the situation realistically, and it is depression and anxiety provoking. And then comes the stage where one is trying to accept the eventuality of one's situation, especially if it is chronic and the prognosis is poor. But if it is acute and the prognosis is good, then you don't go through all these phases because then the focus is that I'll get over this disturbing thing or threatening thing in just a few weeks' time. The last phase after acceptance is hope and focus on a new focus on life. So one is hopeful and then is thinking about what to do next in life. So this is how we human beings go through a process, a psychological process, to eventually accept our situation. But if it is pretty acute type thing, then most of us may not go through all this. We may just go through a sense of denial or shock, and then some type of reassurance or some type of realistic expectation can just make us accept it and move on. So the signs and symptoms of depression are important to know, and there are a lot of different questionnaires that are available to use. Say for example, if we are assessing, say, anxiety, there are questionnaires that can be used. Say, for example, there are questionnaires nowadays where you can assess the whole mental state and most commonly seen mental health conditions such as depression, anxiety, say alcoholism, eating disorder, or somatoform disorder. So not all of those would be pertinent to a given specialty, but they can give you a fairly good idea of 5 conditions which are commonly seen in the general population. So either one can use that kind of questionnaire. It's called Prime MD, PRIME. Then there is MD like MD in the end, and this is available in 2 forms. One is diagnostic for the doctor, and then there is one form which is self-administered by the patient. And so we can use both of them, and they are pretty good screening tools. And then, of course, if somebody is in pain, we can always use some kind of screening test for the pain, and that can give us, say, for example, for the pain, one can do brief pain inventory. It's a very simple and easy to give, out what you call bedside test. And then there is another one which includes pain and mood condition, which is called Memorial Pain Assessment Scale. So we can pick up, scales as per the kind of work we do, and use them as objective means to assess the state of the person or mental health of the person at the time of treatment, as well as after the treatment or during follow-up. Now, in terms of drug-seeking behavior, sometimes you guys probably have to prescribe medication, and you want to make sure that you do not contribute to somebody's, ill health. Say, for example, you don't want to contribute drug addiction to somebody who's already dealing with so many different medical conditions. So in order to kind of briefly assess that, there are a few questionnaires that have been put together by different doctors over the years. The most common one is called CAGE criteria, CAGE, and this is generally used to assess somebody's propensity for heavy drinking.
Right. And Dr. Chaudhri, sorry to interrupt, but we're actually a little over time, so we could just wrap up in the next few minutes. We really provided us with a lot of good information, so if we could finish off with the questionnaires, that'd be great.
Sure. I think what we can take home from this is that there are questionnaires present for alcoholism, for drug-seeking behaviors. There are questionnaires present in terms of prescription drug-seeking behaviors, as well as illicit drug conditions, either abuse or addiction. So there's a lot of help in terms of objectifying the potential for some kind of misuse of the prescription medication. Any questions you may have, Dushyant?
I think that is really phenomenal, Dr. Chaudhri. Unfortunately, we don't have a lot of time, but you really covered in at the same time a detailed manner and at the same time a succinct manner a lot of the issues that we may encounter as clinical interventionalists. Just to summarize briefly from what I took away, Dr. Chaudhri, you first went through how to approach a patient, namely since we're seeing patients for oftentimes for the first time, we should be friendly, we should be professional in our demeanor, we should acknowledge family members, we should certainly, as we're discussing the risks and benefits, identify the benefits and the principal benefits that the patient will experience and ease into the risks, at the same time not being not dilly-dallying and setting unrealistic expectations, and later on throughout the interaction identifying cues of anxiety, which you really went through very nicely as far as the neuroanatomy of it, cues being sweating, dry mouth, mannerisms, either asking for leading questions to reassure the patient, or very curt, short questions, indicating fear. Also, throughout the interaction, not just explaining risks and procedures, using the opportunity to screen for issues such as depression, which you mentioned go hand in hand with anxiety. Up to 25% of the population suffering depression, and that must be addressed, as that can lead to physical poor outcomes, irregardless of how well the procedure may go. The patient's depression will affect negatively their eventual outcome. Then certainly you went through in a very nice form specific populations such as cancer patients going through various stages, including denial, anger, bargaining, depression, eventuality, and acceptance to hope, and how to sort of identify those predictable reactions, particularly in patients with poor prognoses. And then finally, you went to identify and suggested some really good resources for additional patient populations, such as pain seeking, or to overall objectively identify in a holistic manner different issues that may be present, such as anxiety, depression, and pain seeking. One example which you gave was Prime MD and MD the End, we're two resources that we can use to objectify this if we may not have the experience that you have in our clinics. So again, thank you so much, Dr. Chaudhri. If there's anything that I missed out, certainly what we can do is set up another webcast, a webinar in the future. I'm sure we'd be very interested to get your thoughts on additional topics that we weren't able to cover this time. Thank you again, Dr. Chaudhri, for doing this, for agreeing to do this, and lending us your time.
Well, let me thank you again, the chance for considering me for this very important, interface of psychiatry and medical fields. I'm very passionate about this, and I'm glad that you contacted me, and I'm sure we'll stay in touch.
Sounds good. Thank you again.
Take care. Bye-bye.
Bye.